For the next presentation, I would like to call Dr. Arzoo Fatima Saleem, who would be delivering a talk on PET-CT in lung cancer. Since it is her second talk of the day and much has been already said about her introductory remarks, all I would like to say would be that she is a well-experienced, seasoned, competent, dynamic nuclear medicine physician working in old Lahore. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum again. And thank you again for being here after lunch. I see quite a few people sitting here. So I'll begin without further ado, and I'll try to finish it in 20 minutes. But just to comment about Dr. Kaisar's talk, it was really very interesting, very comprehensive, and changed a few concepts. So thank you so much. Okay, so this is going to be the layout of my talk. Very briefly, the background of lung cancer. I'm sure you're all familiar with it. And then the indications for PET-CT. And that should be followed by some clinical cases, and finally some key takeaways. So according to the GloboCan data 2020, lung cancer was the third most common cancer in incidence and mortality in both genders. But in 2022, the statistics change worldwide as well as in Pakistan. As you can see, in Pakistan in 2022, lung cancer has become the second most common cancer in incidence and mortality. It is preceded only by cancers of the lip and oral cavity. If the current rates were to remain constant over the next 2 decades, lung cancer will claim around 2 million male deaths in 2040, compared with 1.2 million in 2020. Lung cancer, as you all know, accounts for about 1 in 5 cancer deaths each year, and the key determinant remains tobacco consumption. It accounts for an estimated 25% of all cancer diagnoses. Highest incidence is still in Europe and North America. And the risk factors include this list: older age group, but smoking still independently remains the most important risk factor. Other risk factors are much less common. Likelihood ratio between smokers and non-smokers is 10:1. About 80% of lung cancer deaths are linked to smoking. So the choice is yours, but do not be late. Types of lung cancers, as we all know, 2 major types: non-small cell cancer, which accounts for 85 to 90% of the cases; small lung cancer, 10 to 15%. Most arise centrally, are large and lobulated, invading the mediastinum and hilar. Aggressive tumors, frequently metastatic at diagnosis and treated with chemotherapy. 5-year overall survival for small cell lung cancer is just 6% as compared to non-small cell lung cancer, which is 17%. Types of non-small cell lung cancer: adenocarcinoma is the commonest, accounting for 40%. Most common in non-smokers, has a peripheral location, tends to grow slowly, and is less FDG avid. Squamous cell carcinoma, 30%, closely linked with smoking, has a central location. Most common subtype to cause cavitation, tends to grow and spread quickly, and is FDG avid. Large cell carcinoma, 10 to 50%, can appear in any part, tends to grow and spread quickly, and is FDG avid. So let's look at the indications of PET-CT in lung cancer: staging, of course, response evaluation, prognosis, radiotherapy planning, surveillance, and follow-up. We'll see when we come to the last one. So let's take a look at these indications in the light of the latest NCCN guidelines, which were updated just a few days ago. That is on October 15th, 2024. Now, according to these latest guidelines, PET-CT is best performed before a diagnostic biopsy site is chosen in cases of high clinical suspicion for aggressive, advanced stage tumors. There's a twofold logic of PET-CT prior to biopsy. Tissue samples must be useful not only to provide histological diagnosis, but to stage the disease as well. According to NCCN guidelines, it's preferable to biopsy the pathology site that would confer the highest stage. That is, to biopsy a suspected MET or a mediastinal lymph node rather than the lung lesion. Tumors may be associated with post-obstructive pneumonias. Tumor masses may have extensive necrosis. PET-CT will therefore provide valuable information for pinpointing the biopsy site, and according to the NCCN guidelines, PET imaging will determine the tumor viability at the proposed biopsy site. I think I'll skip this one. Okay, T-staging. FDG avidity by tumor depends upon two factors: tumor histology, that is tumor cellularity and the amount of mucin; tumor grade. Low-grade, well-differentiated tumors are less avid. Now, coming to end staging, importance of lymph node staging in lung cancer. It is one of the most reliable indicators of prognosis and is essential for treatment decisions. PET-CT represents the best non-invasive modality for the detection of nodal METs due to two reasons. It is able to identify small hypermetabolic lymph nodes that are negative under CT morphological criteria. Plus, it is able to identify enlarged lymph nodes with little or no uptake that are either reactive or residual. Many studies have shown that the sensitivity of PET-CT is better than CT, MRI, and comparable to that of mediastinoscopy. Sensitivity of CT-MR is 50 to 60%, that of mediastinoscopy is 87 to 91%, and PET-CT is 85%. Negative predictive value of PET-CT is very high, 99%. Now, this means that if the primary lung tumor is FDG-avid, but there are no FDG-avid lymph nodes, then PET-CT has virtually ruled out any lymph node METs with a high degree of precision. Proper metabolic mapping of mediastinal lymph nodes allows ultrasound-guided transbronchial needle aspiration, particularly in areas that are difficult to access, such as the AP window and the subcarinal area. So change in stage is documented in up to 20 to 25% of all cases. Well, false positives can be seen in case of inflamed nodes. Various SUV max cutoff values have been proposed by various studies. The SUV, as we all know, is dependent upon many factors, including different scanners, reconstruction methods, and also the body mass index. In clinical practice, SUV value is often quoted in relation to mediastinal blood pool, and if it is more than that of mediastinal blood pool, and keeping in view the location and size of the lymph node, sampling through endobronchial ultrasound bronchoscopy is often suggested. M staging. METs are present in nearly half of the cases. Treatment is, of course, radically modified, and PET-CT detects these unsuspected distant METs in up to 30% of the cases. PET-CT is the study of choice due to two reasons. There is high FDG uptake in lung cancer METs, and plus the PET-CT has the ability to explore the entire body in one study without incremental radiation exposure, unlike CT. So the common metastatic sites are bones. They are obviously the commonest. Brain. It is, in fact, the most common cancer that spreads to the brain. This can occur with both non-small cell as well as a small cell lung cancer, but is known to develop rapidly with small cell, liver, and the adrenals. Now, why PET-CT is superior in bone mets? More than 50% of bone mets involve only the bone marrow, without significant destruction of bone structure. X-ray and CT are unable to detect them. Bone scan also has a low sensitivity for this type of lesion. Purely lytic bone lesions tend to be FDG-avid. They may not show increased uptake on bone scan if there is no associated osteoblastic activity. Brain mets are quite frequent, like I said. Their presence results in a high morbidity and mortality rate. PET sensitivity for detecting brain mets is limited because brain cells use high quantities of glucose in their basal state and therefore can be disguised by the high physiological uptake in brain. MRI is recommended by current protocols to stage the brain. In case MRI is not available, then CT with IV contrast is recommended when PET-CT images are being carried out. PET-CT allows evaluation of the sites which are not covered by conventional imaging studies. So, coming to response evaluation, PET-CT is expected to improve accuracy and early diagnosis of progressive disease because changes in cellular metabolism, as we all know, occur more rapidly than do changes in tumor size. By providing information on the metabolic activity of tumor cells, FDG-PET has become a powerful tool in assessing treatment response. PET response evaluation criteria in solid tumors has been shown to be a better predictor of histopathological response than the anatomic response matrices such as the WHO criteria and RECIST 1.1. Now, Hopkins criteria, as was mentioned earlier by one of the speakers, is a PET-based structured qualitative treatment response criteria. The 5-point scale is defined according to the intensity and pattern of FDG uptake, considering mediastinal blood pool and liver FDG uptake as the reference standards. Role of PET-CT in prognosis. Prognostic factors include stage, grade, age, performance status, and response to treatment. Now, stage is the major prognostic factor in lung cancer. As you can see, the 5-year survival for stage 1 is 70 to 90%, and for stage 3B onwards, it's just 0 to 10%. So precise TNM staging provided by PET-CT makes it a prognostic tool per se. Role of PET-CT in radiotherapy planning. Well, it is important because of the ability of PET imaging to differentiate viable tumor tissues from atelectasis, post-obstructive pneumonias, and fibrotic changes. It defines the limit of the tumor with precision, thus preventing mistargeting and unnecessary radiation. It significantly improves targeting accuracy, and given the potential for rapid progression of non-small cell lung cancer, it should be obtained preferably within 4 weeks before treatment, ideally in the treatment position. PET-CT has a high impact on radiotherapy planning, and its incorporation results in a change in target volume in more than 20% of the patients. So finally, the role of PET-CT in surveillance, however, according to the latest guidelines even, it is not currently warranted. However, many benign conditions such as atelectasis, consolidation, and radiation fibrosis, which are difficult to differentiate from tumor on standard CT, there FDG can come into play and can be used to differentiate true malignancy in these settings. If FDG PET-CT is to be used as a problem-solving tool in patients after radiotherapy, then histopathological recurrent and confirmation of recurrent disease is needed because areas previously treated with radiotherapy can remain FDG avid for up to 2 years. For routine surveillance, chest CT plus minus contrast is recommended every 3 to 6 months for 2 to 3 years, then annually. False negative findings can be due to a small tumor size, tumor histology, as well as certain other factors like diabetics and non-fasting patients. False positive findings can be seen in granulomas, infections, inflammations, and adenomas. Quickly, some of the clinical cases. Well, case 1, non-small cell lung cancer for staging, true-cut biopsy of mass right upper lobe. The images show a hypermetabolic mass in the upper lobe of right lung, having a AP dimension of 83 millimeters with extrathoracic extension and rib erosion. Hypermetabolic chest lymph nodes. Now, the T stage is T4 as the largest diameter is more than 7 centimeters. N is N3 because bilateral hilar lymph nodes are involved and there is no distant mets. So what is the prognostic stage? T4 and N3 make it stage 3C. So teaching points here are, according to TNM staging 8th edition, Chest wall invasion is categorized as T3 disease regardless of the anatomical structures involved, whether it's parietal only or intercostal soft tissues or ribs. Now, this chest wall invasion is found in 2 to 8% of the patients. The 5-year overall survival is reportedly worse in these cases. CT is unreliable in staging lymph nodes, like I mentioned earlier, regardless of the threshold size, and PET-CT is much more reliable. False positives can occur with sarcoidosis, TB, and other infections. Because of the high negative predictive value, PET scanning should be performed in all patients considered for surgery. FDG uptake higher than the blood pool is suspicious, and uptake higher than the liver is highly concerning for nodal mets. So, what stage lung cancer is considered resectable? Well, stage 1 and 2 disease is generally resectable, and stage 4 disease is almost always unresectable. What about stage 3? This is the gray zone. Only selected patients with stage 3A disease are resectable. Almost all patients with stage 3B are unresectable. Case 2. Well, this patient, as you can see, has multiple areas of increased tracer uptake. Let's see what these indicate. These images are showing a hypermetabolic lesion in right cerebellar hemisphere, hypermetabolic lesions in left lobe of thyroid and right scapula, red arrows, hypermetabolic bilateral supraclav lymph nodes, white arrows, yellow to be precise, and hypermetabolic left hilar lesion. And what about this? Well, hypermetabolic lesions in the left iliac bone and sacrum. So what about the T stage? It's T2 because the tumor is between 3 to 5 centimeters. Again, N3 because here you can have distant, that is supraclav lymph node involvement, and M1C due to multiple extrathoracic mets. Prognostic stage is because of M1C and N3, stage 4B. How is PET-CT superior in this case? Well, it has scanned the entire body from skull to mid-thighs in a single study. It has discovered distant mets in skeleton and nodal sites of neck, chest, and abdomen. It has discovered a possible rare site of metastases, that is thyroid. It has also discovered brain mets, and it has basically resulted in upstaging the disease. Now, one case of response evaluation. As you can see, this patient underwent true cut biopsy 5 months ago, chemotherapy 4 cycles, and you can look at the baseline and interim images. What do the baseline images show? A hypermetabolic pleural-based mass in lower lobe of left lung. What about the interim images? Well, there is an increase in metabolic activity, which has now become more infiltrative. You are better able to appreciate the infiltrative nature of the mass on these coronal images. Baseline images, multiple hypermetabolic nodules in bilateral lungs. Interim images, marked increase in the number, size, and metabolic activity of these nodules. So PET-CT findings are suggestive of overall disease progression. So, coming to the key takeaways, PET-CT is the method of choice for accurate staging of lung cancer. Accurate staging is a crucial step in selecting the most appropriate therapy and in determining the prognosis. It changes management in 30 to 40% of the cases. For proper encephalic staging, brain MRI must be performed. In assessing treatment response, FDG PET has become a powerful tool. In radiotherapy planning, it significantly improves targeting accuracy. However, for routine surveillance of patients with non-small cell lung cancer, FDG PET-CT is currently not warranted. In short, it does result in better workup and management of patients with lung cancer. Thank you. I hope I was on time. And I will take this opportunity, because I don't think I'll be coming up on stage for the 4th time, to thank Dr. Shazia, Dr. Azra. Do I see Dr. Inam here? As usual, he's the man behind the scenes and is not around. And of course, Dr. Babar as well. And as usual, you people have put up a great show. And so far, this has been a very interesting event, full not only, with engaging talks, but with unforgettable encounters. So thank you very much. Thank you so much.